One of the diagnostic tests that we do in the office is cone beam CT scan. So I wanted to just do a general overview of cone beam CT scanning and why we do it at the Hauser Neck Center, and maybe a few of the cases that I've recently seen and how just the cone beam CT scan has helped the management of the patients here and even changed the management of what we thought the person was going to need before they even came. And this is actually what it looks like. This is me in it. You could see it's upright. It's not very big. The whole scanning takes like less than 5 minutes. You're actually, when the scanner is going around the person's skull, their jaw, their neck, that only takes like a minute. So, and the cool thing about a cone beam CT scanner is it's upright versus traditional CT scan at the hospital is where you're laying down. And this is me standing up. So we can scan somebody when they're standing up, sitting down, and also we can move the neck. So you can see the 3D anatomy of the bones in the neck and the jaw in different positions. And this is the difference. A traditional CT scanner does slices. So CT scanning is computerized tomography. So it's basically X-ray beams with different angles, and it's basically a computer making an image of it, and you can modulate that image just like we can change the image, if you will, by the computer. I can make the image darker, I can make the image be lighter, I can change the angle. So you'll see images and turn them upside down. We can make the bones look real white. We can have different shades depending on what we want to see. What we're going to go over is you can actually see the atlas in 3 dimensions, and then if somebody has an elongated styloid, you can actually look and visualize how much space there is between the styloid and the bone. But you see that a cone beam, the X-ray image is a cone, where this is a slice. So the advantages of, say, traditional CT scanning is you can do like contrast. Not that we can't do contrast with this, but normally you don't do contrast when somebody's upright, because in case somebody has a reaction, you'd prefer to have them laying down. So almost all, well, 99% of the contrast is with the person laying down. So that's one of the advantages. The quality of the image, the clarity of the image is better because there's more images taken here. The advantage of the cone beam, of course, is it can be done very quickly, doesn't cost as much. It can be done in a doctor's office. It also is in the upright position. And as you guys know, with dynamic structural medicine, we like to do images usually in the upright position because that's the symptomatic position that most people have. This is actually me looking at my scan. So I'm looking at my scan, and you might say, well, how do you know it's my scan? Well, look, like those are my glasses. So the image quality is very, very good. And see how, remember I told you guys I have an elongated styloid on my right? As a matter of fact, the other day, this was actually yesterday, I was going into the break room and I turned my head really quickly, and I'm just telling you, my trapezius and my sternocleidomastoid muscle just went like that. It was like unbelievable. So in other words, what I did was when I turned into the break room, I had turned my head so quickly that my styloid bone hit my carotid sheath and probably irritated my spinal accessory nerve, which goes to my trapezius in here. And it took like probably 10 minutes for that sensation to go away. So it's not that I talk about all these things, like I experience these things. So I know what carotid sheath compression is or jugular vein is because I have some of the symptoms. And again, this is Izzy, who does the filming here. She's behind the camera today. What I wanted to do is just show you it's so sensitive, and all I had Izzy do was change the configuration of her jaw. So this is with retraction, that's with protraction. So you could see where, how her jaw is protracted out. At another video, we'll show that how Izzy's jaw motion, just the jaw motion changed the configuration of her atlas or axis C1, C2. Because some of you guys know, you just know there's a connection between the jaw, the TMJ, and the upper cervical spine. So Izzy just did some different images. You might say, well, didn't she get a lot of radiation exposure? In another video, I'll talk about that. I'm going to talk about it a little bit here, but the CT scan, the cone beam CT scan radiation is about 1/10 that of a traditional CT scan. So, and then I'm going to show how it is compared to just walking around on planet Earth. The traditional cone beam CT scanner gives you about as much radiation as walking on planet Earth for about 1 to 2 months. So I don't worry about walking on planet Earth and I'm going to get cancer or something because of the radiation just by walking on planet Earth. So neither should somebody who's getting cone beam CT scans. This is where she moved the bite to one side, and we'll show you how that changes the anatomy of the atlas and the axis. Okay, so I got Eddie out here, and then after I do this, I'll give it back to Izzy. But this represents the carotid sheath. So the carotid sheath normally is compressed because of where the atlas is. So if somebody has forward head posture, the atlas then compresses the carotid sheath. The jugular vein specifically goes between the atlas and this bone called the styloid bone. So you see in Eddie, there's a styloid bone. Well, I just fractured Eddie's styloid bone. Wow, that was cool. Here, we're gonna go to the other side. So actually I'm gonna have to repair Eddie's styloid bone. But the good news is, see how his styloid bone isn't bothering him anymore. So if the styloid bone was compressing Eddie's jugular vein, here Izzy's cracking up like, oh my God. So no, but some people need a styloidectomy. So I just did a styloidectomy on Eddie. Like you saw it live, like what could be better? Okay, so we'll go to the other side. So the jugular vein in many people who have an elongated styloid, including me, it has to go between the styloid bone and the atlas. The normal jugular vein is 9 to 10 millimeters by 9 to 10 millimeters. So ideally, there needs to be 9 to 10 millimeters of space. So you could see that the jugular vein can be compressed by the styloid in the front or the atlas in the back. So in this particular patient, the cone beam CT scan, you could see the atlas here, and then that's the styloid, and there's only 2.25 millimeters on the person's left, and on their right, I couldn't even measure it, so it's less than 1 millimeter. So this is a patient who it's possible they might need a styloidectomy just because the space is so narrowed that even if we correct their curve and increase the space by 2 to 3 millimeters, the jugular vein is going to be too compressed. And always remember, if the jugular vein is getting compressed, probably the other things in the carotid sheath may also be getting compressed, such as the vagus nerve, the glossopharyngeal nerve, that's swallowing and blood pressure, and the spinal accessory nerve, which I talked to you about, that relates to my condition. This is another patient, so see right here, see how there's a non-union of the atlas, a non-union. So this particular patient was born where the posterior arch of the atlas didn't fuse. So of course that's going to lead them to increased instability. And see here where the right occipital bone is fused to the atlas. See how it's fused here with bone? This particular patient had a lot of left-sided problems and they had instability on the left side. So that would be a patient where we may or may not be able to get them completely better because the right side isn't moving and the fusion here is causing all the motion at the occipital C1 to occur on the left side. So the person may actually end up needing surgery. So that's a case where the cone beam really added a lot of extra knowledge that we needed to take care of the person. So the good thing about cone beam is We can see whether they have a good lordotic curve. We can do various measurements, angles. And then if somebody has, let's say, a bad curve, let's just say they have that curve, we can measure how far the atlas is forward compared to other vertebrae. You can't really see this, but we could see that the atlas right here is subluxed or is forward compared to the C2 vertebrae. So we can measure, let's say it's 3 millimeters. We know that there's a 3 millimeter anterior subluxation of the atlas onto the axis. Then if the C2 is rotated on the right and the person has a lot of cervical vagopathy, vagus nerve degeneration on the right compared to the left. In other words, we did an ultrasound on the vagus nerve on the right, and let's say it was way smaller than the left. Well, you can make a clinical judgment that it's because the C2 vertebrae is malrotated. The CT scanner can tell us exactly how much is rotated. Then, and at any later date, if you want to see exactly how the alignment is or the curves are, you can get objective data. Then this is a real key thing. The C0, C1 joint can be clearly seen, and I'll explain how we diagnose instability in that. It's very low dose radiation. It can be upright or the symptomatic position. For instance, if somebody said, "Doc, I'm just telling you, I get massively dizzy when I rotate my head to the left," well, we can do a cone beam CT scan when they're rotated to the left. So then we see the exact symptomatic position. You can do analysis of the TMJ, and of course you can get quantification of the cervical spine alignment and how far forward the atlas is. And then it also gives us findings that can change the treatment course, and these are some of the things. There's a condition called semicircular canal dehiscence where there's an issue in the temporal bone that affects the inner ear, and sometimes you need surgery for that. Believe it or not, your doctor, Dr. Hauser, has a little bit of carotid artery atherosclerosis, so my cone beam CT showed that, and the reason why I have that is over the years, because of the athletics I've done, the Ironmans I've done, the hunched over posture, my whole career I've turned my head to the right, so I've gotten treatment on my neck for instability on the right side of my neck versus the left side. And over time, if you have instability, even if it's subtle, what can happen is, in my opinion, you can stretch out the carotid artery on that side of the vertebral artery, stretch it out to the point where you get little tears in the intima, and then the body's response to repair that is to put calcium there. And atherosclerosis is known as hardening of the arteries. It's very, very mild in me. I'll have scans probably once a year. So I had Karina do an ultrasound on my carotid artery, and it was, you could barely see it, but it's definitely something for me to watch. And I don't want to be, if God gives me 85 years, I don't want to have a stroke when I'm 83 on the right side. So that's kind of interesting. We talked about the styloid bone. Also, you can get obstruction of the carotid sheath by the hyoid bone. The hyoid bone sits right here, and some people, for various reasons, trauma, born that way, they can have elongation of that bone, and that can obstruct the carotid sheath. Arthritis, like the cone beam, gives you amazing detail as far as bone spurs and what effect those bone spurs have on the spinal canal and the neural foramina. We talked about malrotation of the cervical vertebrae. I'll be making all kinds of videos in the future about breathing, because it's unbelievable, the cone beam, how it shows where the narrowing is for the airways going from the mouth to the lungs. And I'm getting more and more convinced that there's a substantial subset of sleep apnea that the primary cause is actually the cervical curve. So that'll be really interesting. You can get the density of bone. Well, I should say you can see the bone, and you can tell basically the person has osteoporosis or they don't. So, you know, if you want to get a quantification of how bad it is, then of course you get a bone density test. You can obviously see the dens, whether it's retroverted, which again would be a sign of instability. You can see intracranial calcifications and, like I said, narrow pharynx or airway. Look at that styloid. So you can definitely see the styloid can go to the level of the atlas. The styloids are not supposed to go to the level of the atlas because the jugular vein goes between, in most cases, between the styloid and the atlas. So the styloid bone is not supposed to go to the atlas. So see that little space there? That's where the jugular vein goes. So we can measure how big that space is. And again, there are people that need styloidectomies. And of course, earlier in this video, I showed you how a styloidectomy is done. Okay, and then this particular person has breaks in their styloid bone. So it turns out that people who have incomplete or breaks in their styloid bone, because the bone isn't as strong because there's breaks in it, it doesn't compress the jugular vein or the carotid sheath as much. So that's important to know as it relates to long-term management. This is what we typically see. In this particular patient, it was 10 millimeters on this side and like 9 millimeters on that side. So that's normally what we see. That means that in general, there's enough space. This is kind of like what mine is on the right side. So normally I have plenty of space. Say I decided to take up tennis or something, or I got back to long distance swimming and I didn't have good form and I kept bang, 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 bang on the right, because if I go like this space goes down. Well, it's actually on the right side. This space goes down. So just means that I have to be careful somewhat, you know, turning quickly to the right because I have that elongated styloid. This is just going to show you atlas misalignments can be found. It can narrow the space in the foramen magnum. That can block CSF flow, and that, of course, could lead to intracranial hypertension. Then you can see here, you can look up the spinal canal and see where, if there's misalignments of the vertebrae, that the spinal canal space is narrowed. You can get cross-sectional areas of the spinal canal space. You look at all these vertebrae, you can see all the misalignments. So of course, Dr. Hutchinson in our office, he'll look at that, and that helps him know specifically where the malrotated vertebrae are and how to properly adjust them. You can look at the overall curve, like you can have scoliosis or lateral spinal misalignments in the curve in the cervical spine. You can see areas where there's increased pressure, that there's been hardening of the bone. See how the bone is real white here, but it's not down here. You can see bone spurs. This is on the atlas, so obviously this person had upper cervical instability for a long period of time where the body was overgrowing bone to stabilize. And then what we're next going to show is a video where you actually see a cone beam CT scan where Brad is actually analyzing it, and he's one of our nurses, and he's awesome. Thank you for watching.
Hey guys, Brad here with Caring Medical, and today we have something very exciting to show you. What we're going to look at today is C0, C1 instability, which we can see on our new CAT scan to show us a misalignment or subluxation of the skull to the C1 joint. So let's take a closer look. So this model demonstrates the neck and the skull. What we're going to look closer at today is how the skull, with this groove here, sits into C1. So what we're going to try to look for on our CAT scan is if the C0 is sitting into C1 appropriately. When you have it in appropriately, they look flush, they look lined up together. But what can happen on some of our patients is that it's subluxed. It's actually slightly out of joint, which of course can lead to other symptoms and indicate joint instability at this location. All right guys, so this is one of our CAT scan images. And what I'm going to point out right here, this right here is the base of the skull. And this is C1. Now what we should be seeing is that this line right here should be in line with this line from C1. They should be right on top of each other. But as you can see, they're slightly displaced. So with some assistance, we're going to go look at this joint a little bit more closely. And as you scroll down from right to left, we're going to see, you can freeze there, this joint is not lining up whatsoever. But let's look through on the other side. So as we keep scrolling down, keep going, right there. Do you see how this side, it's nice and flush? This is exactly how a C0, C1 joint should look, but when there's some ligament laxity, you might get some subluxation of the C0 at the C1 level, which we saw on that other side.